Good morning, Aaron. And for a change, today's presentation, quite unusual for me, has only touching on the technological side of things. So let's see, get my screen share up here. What we're talking about today is clinical decision making, and in particular, what I want to talk about is the specific issue of how we think and some deficits that we found in terms of thinking in our learners. So usual disclosure stuff, don't have any conflicts of interest, worked for years in that, trying to develop some and been spectacularly unsuccessful in that. No financial support, no conflicts of interest there. And the images that we have in the presentation are licensed by Creative Commons. So if you want to reuse them, you're welcome to. Please just tell folks where you got them from, etc. I would like to acknowledge that the usual acknowledgement of that we're on treaty lands, and especially in Calgary with Métis Nation 3. We did have some preparation with virtual cases ahead of time on a previous workshop where it was fairly important. I'll point out these for later so that you can tackle these if you haven't come across them before. And the materials from this workshop, you can get to them from this link as well, which is some additional material. So, pearls for teaching, clinical reasoning. So we're going to talk a little bit about System 1, System 2 thinking, and I'll show you a couple of virtual learners that we created for this. We'll maybe spend a few minutes gathering some more stories from you guys about some experiences that you've had, touching upon the effect on the preceptor. This can be quite damaging and spoil teaching careers, and finish off with some practical tips on what the heck you do when you're stuck in some of these situations. In 30 minutes, it's not really a workshop, but I am happy for people to jump in and rebut, make counterpoints. I'm happy to make this argument in a debate. If we don't cover all my slides, I am fine with that. All right, so some of the special challenges, rather than special education, some of the special challenges that we've seen brought to light. And then we went through a spell in our particular module of having some particularly challenging learners, and there's got a group of us trying to tease out what it is we were seeing and what do we do with this. Many of the challenges came down to clinical decision making, and it also got us thinking about what do we actually mean by that phrase. It tends to be it's a little bit like shoulder stuff. It's the rotator cuff syndrome. It's a bit of a catch-all. And there's many pieces within clinical decision making which can be awry or break down, multiple ways in which dysfunction in your learners presents in this area. So it's a broad term. There's been quite a lot of work on this over the years, and a lot of it has focused on the work of Dan Kahneman, who's well known along with Amos Tversky for a number of things like economics and stuff like that. But his fairly recent book certainly got a lot of interest in the field of education and medical education, Thinking Fast, Thinking Slow. And then this Kahneman presents the idea of that we have two basic ways of problem solving. One being, so System 1, which is a rapid rule of thumb, essentially heuristics, and System 2, the slower, more plodding, more algorithmic form of thinking. And he makes some very good points in his book, and he writes well and is being very catchy. However, there are problems in this. And so first of all, I'd like to point out that dual process theory, or having two ways of thinking, etc., is actually much older than Kahneman. This is not something which he coined himself. He did a brilliant job of summarizing and popularizing it, but it goes back way back into the 19th century when it was first described. This is not new stuff, but it keeps popping up. The other thing which a number of us are uncomfortable about is that Kahneman spurred off a big drive that heuristics are bad, heuristics are sloppy, that heuristics are hugely prone to error, and we should be discouraging them. And a number of others have also been pursuing this, probably in medical education. One of the most notable authors in this area, Pat Croskery, who's an emergency doc, which I find slightly ironic because emergency docs use heuristics all the time. But anyway, Croskery and others have been basically preaching the mantra, heuristics are bad, they're sloppy, they're so prone to error, we should train our students out of doing that. The problem with that is that it's all very well saying it's bad, but it's what we do all the time. It varies from discipline to discipline, but things like emergency medicine, rural medicine, family medicine, primary care, we are heavily dependent on heuristics. And if you try and make yourself too oriented towards system 2, it's too slow. Heuristics or system 1 work fine for us. We're often not even aware that we're using them, but it is, if you look at how expert thinkers do their decision making, the vast majority of it has been quoted as 95%, although the stats on that are pretty sketchy. It's like that old saw about 78% of statistics are made up on the spot. Exactly. So it's fast, but it can be faulty, and we should recognize and acknowledge that. But the counterpoint that is being pushed on us, to say, for the last couple of decades is that algorithmic thinking, following pathways, taking it steady is much more reliable. And there's quite a bit of evidence that that's not true, that it's not fault-free. We had a very interesting example of this with one of our residents recently, where he was pointing at and referring to a clinical pathway and an algorithm that he was following for a case on dyspepsia, except that clinically he had picked the wrong algorithm. This was a patient who was presenting with GERD and reflux, and he'd picked the peptic ulcer algorithm. And they're similar, but they're not the same. And it was leading him off down a rabbit hole of inappropriate investigations, etc. So it comes down to that. If you don't pick the right algorithm, you're still going to be at fault. The key thing is that most of us are able to swing from system 1 to system 2 fairly smoothly. We use system 1 a lot of the time, and when we get stuck, or when there's a little flag that goes, hang on a second, I'm not sure this is actually a simple case of blah blah blah, then we drop back into our system 2 and work through things more algorithmically, either from a known algorithm like a pathway, or sometimes just our own internally generated if then else side of things. It is something that the vast majority of learners as well learn to do. And it is a sign of maturity that early medical students really struggle with this and are very dependent on system 2 stuff. And as they begin to pick up and as they progress through residency, they become quite adept at being able to show this balance between heuristic thinking and algorithmic thinking. And we do evaluate for this. If you think about the ITRS and stuff like that, we ask about things like specificity and selectivity in their thinking, and are they able to piece things together? Do they over-investigate, etc.? So for most learners, it works fine, and it is a sign of a maturing learner. Now, one of the problems is that we tend to assume, and there's tons of papers along these lines which are all saying, yes, not everybody gets it and still struggle with it, but it's okay because you know what, they all get it eventually. Except that's not true. I'm going to highlight this with a case that David Keegan and myself, along with a couple of other experienced preceptors, really struggled with about 10 years ago. This was a resident who came back to us on, and is often the case, late in the 2 years of his residency, and was flagged as not doing well. And so came to us for mediation. And it was very interesting because this guy was smart. He had never had trouble with exams and tests, etc. He could regurgitate facts, etc. He was also very good socially. Patients loved him. He interacted well. He was quite a social engineer. You could watch him working a room. He was very popular with preceptors, with his co-residents, etc. And you kind of think had all the makings for somebody who would be a star physician or a star in any role. And part of the issue was that he also clearly thought himself a star. Now, in working with him, it was very clear that his decision-making was bizarrely faulty. He would take a set of symptoms, piece them together based on cases from that he'd come across in the past, and put them together in the weirdest jigsaw. And frequently his top diagnosis, and you did not what's the most important thing, what's the most likely, he would come out with the most bizarre zebras and odd diagnoses. At the time, we struggled to figure out what was going on with this chap, and we were not aware of the work on heuristics and stuff back then, although it had been published. We did recommend that he be assessed by somebody with a greater degree of knowledge in cognitive psychology, etc. Unfortunately, that got misinterpreted as a learning disability, and he was punted off to somebody who was used to dealing with high schoolers and stuff like that. So that didn't work out well. It was frustrating because while he was really, really good at some things, the basic heuristics of being able to put together what was happening in an undifferentiated presentation, he didn't have it at all. And yet he was bound and determined that what he was going to go into was emergency medicine, which would have been absolutely the wrong career choice for him. We really struggled with that at the time to figure out what was going on, and looking at it more recently with a number of similar learners who are not quite so spectacular but have also struggled, we have found there are some learners who just are not able to do that smooth transition between system 1 and system 2 type thinking, that they're okay if they can plod their way through an algorithm, and generally there's enough information there which will put them in more or less the right place with an algorithm, but they are really slow and very rigid in their thinking. And this inability to move backwards and forwards along the spectrum, the coin was turned initially tongue-in-cheek, but it actually applies quite well. But it's almost a heuristic spectrum disorder, because the bizarreness in some cases almost come across like autistic spectrum disorder. The two are not the same, but there's some odd similarities sometimes. So I wanted to point this out because if you're aware of this difficulty, it's helpful, because being aware what's going on, they can present in different ways. Sometimes they come across as being really slow, which is typically the case. Sometimes they have odd presentations. We created, for a bigger workshop, we did an hour-and-a-half workshop on this at Cabin Fever. This is very much just a reprise of that workshop. But for any of you who want to explore this more, we created some virtual patients, or actually virtual learners, where the patients are residents who present with troubling symptoms. So there's a reverse Rupert, Zebrazac, Glacial Glen, Testy Tessa, and a more troublesome and longer case of lackadaisical Larry, who some of you might be aware of from many years ago. The glacial glen is a resident who's particularly slow, and there's some ways in which to try and get him to speed up. Testy Tessa is somebody who is highly reliant on tests and investigations and over-investigates everything. Lackadaisical Larry is an amalgam of all sorts of problematic cases. Reverse Rupert, and I'll touch on this in a bit more detail just now, is a case where, again, he struggles with this idea of condensing his case. And the main points that comes out of this case, I'll just give you a quick synopsis so you can decide whether you want to actually try the case later, is the idea of reverse presentations. We know that early medical students, and even sometimes later medical students, want to do their nice presentation where they, this is Mr. So-and-so, who's a 65-year-old man, blah, blah, and they have to work their way through the entire story before they can sort of come to what they think is going on. And that, in a busy clinic, can be a little bit frustrating and time-consuming. And often they fizzle out before they get to the nub of the situation, which is, what do you think's going on? And so the idea behind reverse presentations is that you get them to do it backwards. They start with, not quite backwards, because you wouldn't start with treatment. You'd start with what's going on, what else might be going on, what makes you think that, and then present it in any other context. So most likely diagnosis, differential diagnosis, supporting evidence, context. It's a very simple technique. It's similar to SNAPS, which is similar sort of area, SNAPPS. I find that just a little bit more stodgy, but reverse presentations can be very useful in this such a situation. And if you want to learn more about that, check out that case. Zebrazac is, and again, our very challenging case from a decade ago had quite a lot of this tendency, but we see this quite often that you ask them, you might do a reverse presentation, you might do a standard presentation, but again, they tend to focus on the zebras rather than the horses. They come up with the most odd and unusual diagnoses rather than the stuff that's common. And a nice workaround to that is to use an approach that Doug Meyer has been using for a number of years, and that's a 3+2. 3 things you think this might be, and 2 things that you don't want to miss. So that 3+2 approach can be quite useful. So it's similar to a reverse presentation, but you get into focus on the common things and then the important things to exclude. So the 3+2. And if you want to explore that, the Zebrazac virtual learner case gives you a bit more information on that. All right, so at this point, one of the things I want to touch on just for a few minutes are, does anybody have any sort of painful memories or puzzles or learner struggles that they've encountered that they'd like to bring up, either as an example of, oh my God, we had a trouble with, or things, and how did it make you feel? How did you handle it? Anybody want to jump in?
I was just going to say I have a learner, a longitudinal learner right now, and using that, my kind of version of the reverse presentation case was super helpful to help them move towards presenting more succinctly.
Yeah, so I love those techniques. It's quick, it's easy, it's not hard to get your head around. It is a little hard for the learner to do just right off the bat. So sometimes if I'm expecting to do that, I think it's going to be a slightly complex case, I'll send them off to see the patient and say, when you come back, I want you to present the case to me as a reverse presentation, so that they have time to sort of turn the thinking around. But yeah, it's a nice, easy technique to apply. Any other war stories or horror stories out there?
Yeah, we had a learner quite a while ago who had been a teacher, a vice principal, and he may well in the audience, I don't know. Actually, he's not, but did very well in the long run. But we had issues because, and that he was very sure of himself, too sure for what he should be at his level of training.
Mhm.
And it was a real concern of both Dr. Folsom and myself when he went through the pediatric program, because every time there was this certainty that this was this and that was that, not so much because it was done quickly, but just purely because of lack of experience. And I think had to do with his previous profession, being a teacher and obviously being the person in the know. And we addressed that, and basically I think he had pretty good insight in the end. And we basically told him, if you do this as a physician, you're going to be dangerous, and you're going to really hit walls. And I think he took it to heart. I can't remember all the details, been quite a while ago, but it's certainly, he wasn't the only one. We've seen physicians like that, and we particularly have had, we do assessing for IMGs that come in here to work, and many of you do as well, I'm sure. And we've met quite a few IMGs who had some of that. I shouldn't say quite a few, but have had certainly one or two where this was the case as well, that you felt they think they had to show that they knew and prove themselves. And it's an attitude thing, which you have to deal with.
You have a sense, Hendrik, as to whether for your teacher, the chap who'd been a principal, that he was almost too dependent on his heuristics, his system one, and he was just jumping to the most obvious answer and not doing I wonder what else it could be. Because in that sort of situation, the 3+2 can also be useful. But you're right, it's often attitudinal.
Yeah, okay, that's a good recommendation indeed. It's just lack of experience to some degree coming up. But also the certainty was a concern, not could it be, could you second guess yourself, please,
Yeah. And experience is not always our friend. Sometimes as we get more experience, we become too reliant on our heuristics, etc. So that being able to smoothly move between the two. And I think the vast majority of physicians do that well. And we all slip up and we all occasionally blunder, etc. It's not a perfect thing, but the struggle that we had was not recognizing those learners where they were too trapped in one way of thinking or another. Alrighty. So a couple of things I wanted to touch on is that these learners who really struggle or who are on remediation, or where you're thinking, I don't know if we can pass this guy, it can be devastating in its effect on the teacher. We have a tendency to consider when things are not going well that it's our fault. Oh dear, bad me. I've not been a good enough teacher. I have let down this learner. And I've seen this a lot over the years. And it's not that we're all perfect teachers, but it is important, so important, that this is almost always not a failure to teach. You need the litany of, it is not my fault. You are there to provide guidance, assistance, etc. But if at the end of the day, the learner is still struggling and not able to pick up on this, and you've done what you can and picked up on these things, it is, thinking back on sort of teaching for 30 years, I have seen maybe 3 cases where somebody has done poorly purely as a result of lousy teaching. Lousy teaching affects one rotation, and they might get one bad review, but it's not going to percolate throughout a career. But the reverse, where a single destructive learner can kill a teaching career, I have seen that way too often. And it's very, very sad to see. So don't get pulled into the belief that you have let them down. It can be destructive. The important thing is that when you're struggling with stuff like this, remember you're not alone. Do call. So call the PGME office, call the departmental office, family medicine, etc. Call DLRI, Aaron and his team on the rural side, family medicine on our side. It is something where letting somebody know that you're struggling, and earlier the better. The phone a friend. It's also useful just to bounce this off somebody else. Yeah, in the same sort of situation, same sort of clinic. I'm struggling with this. What did you do in this situation? Yeah, the problem shared, etc. The effect can be devastating enough that it has been suggested at times we need a hotline for this sort of thing. And I put that forward slightly tongue in cheek. But I have seen people completely leave teaching because of the frustrations with such learners. So please call if you're stuck. The other very important thing to do is document. So calling the program director or their office, etc., and saying, I have concerns about the office, for God's sake, put it in writing. It's a little bit like the internet meme that's going around. If there's no pictures, it didn't happen. The same thing, if there's no documentation, it didn't happen. Verbal feedback is not sufficient. You have to put it in writing. And there's many reasons behind that, which we can get into. I won't spend a lot of time on that because I'm sure you've been told that before, but it's surprising how often we we'll give them the benefit of the doubt, except that you don't document things. And there's a number of ways to do that. The other quick piece that I'll pass on when you have a learner who's struggling is, well, how do you tell them? How do you give negative feedback? And we've tended, especially in Canada, because we're nice Canadians, to do the old meat sandwich. You give them the good and then a little bit of the bad, and then you follow up with the good again. It might be nice, but too often it gets in the way. Don't give them baloney. Get straight to the meat. Don't do the meat sandwich, etc. But remember, criticize the action, not the person. Be very direct. I am not happy with how this is happening, or that this is what the situation, or that you are doing this. Don't do the you are a bad boy, you're a bad dog type thing. So criticize the action. Very simple things. How are we doing for time here? Last couple of things in terms of, so we have some tips in the materials under precepting challenges. There's a teaching tips app there if you're interested in that. Some quick tips on the technological things that I found helpful. If it's a small thing that you want to document but don't want to send it up the tree and make it part of a formal report, email the resident. Classic thing I do for that is if they don't show up for a clinic, or they've been late in phoning in sick, or just show up half an hour late, I'll send them a little email basically saying, I noticed you were 20 minutes late showing up to clinic this morning. And I'm glad we had a chance to talk about it, or we didn't have a chance to talk about it. But that simple act of documentation is surprisingly useful later, because if it becomes a recurrent thing, quite often the resident will say, but nobody told me. And even email acts as a documentation chain for that. Similarly, in our EMR, we have developed a little thing called teaching observation tasks, or TOTS, which are a way of making case-specific notes about things which have been either good or bad. I won't touch on learning prescriptions just now, but happy to do that at some other point. The last thing in terms of FMECAP is try and make the field notes useful to the learner and build some things for them to reflect in there. We're at time now, so I'll throw it on quickly for any last minute questions, etc. But you're very welcome to email me on this sort of stuff too.
Thanks so